Thank you very much, Dr. C. I imagine when you said, was it really the Dr. Tharpe, you were surprised that I was still kicking and alive. So, so I appreciate that. I am still here and still interested in unilateral hearing loss. So I'm going to share my screen now. Thank you very much, Dr. C. I imagine when you said, was it really the Dr. Tharpe, you were surprised that I was still kicking and alive. So, so I appreciate that. I am still here and still interested in unilateral hearing loss. So I'm going to share my screen now. So I'm going to talk with you, as you were saying, Dr. C, in your very kind introduction. There's a lot we know about unilateral hearing loss that we have come up with over the last 40 years, believe it or not, but still a fair amount that is unknown. And so because we have a diverse audience today, I'm going to share a little bit about what some of you might already know, but I'm also going to expand and I hope share some new information for everyone. First, my disclosures. I do receive funding from these agencies. And I'm also chair of the Pediatric Research Advisory Board for Sonova Phonak that makes a fair amount of the technology along with other companies that aid these children. And I also want to acknowledge at least a handful of my colleagues because I am sharing their work today as well. So to start with, why are we concerned with unilateral hearing loss in children, and can't they just get along with one normal hearing ear? So I'm going to put a few Yogi Bearisms into sprinkled throughout the presentation because he is just incredibly funny, and I know most of you probably have never even heard of him. This is not Yogi Bear. This is not where we came up with the cartoon. But he was a famous baseball player in the 1950s, which was even before my time. But he said, you can see a lot just by watching. And that is the way that my mentor, Fred Best, started his interest in unilateral hearing loss in children. That he noticed that there were a lot of parents bringing their children into our center. The children had unilateral hearing loss. They were having difficulty in school. And at that time, as Dr. C said, everyone, at that point was just saying, well, they're probably going to do just fine. Maybe seat them preferentially so their normal hearing ear is aimed towards the teacher and everything will be okay. But these children were not okay. These parents were saying something's, they're having more difficulty than you said they should. So instead of, he kind of, Dr. Best took it from watching these patients come in to developing one of the first studies in, if not the first study in children with unilateral hearing loss. And you can see here this nice plot, and that big peak right there is in the 1980s when studies started to come out and be published on the topic of unilateral hearing loss. And you can see that prior to that time, there were very few studies on unilateral and mild degrees of hearing loss. And those were primarily for bilateral losses. And then since that big peak in the 1980s, we have seen some steady increases in research and trying to figure out what is going on with these children. Just so that we're all thinking the same way and we're on the same page with regard to what is unilateral hearing loss. Best defined it as loss of any degree of hearing loss in one ear. So on the left-hand side, you see a high frequency unilateral hearing loss, but on the right side, in the right audiogram, you see a severe to profound unilateral hearing loss. Both of those are termed unilateral hearing loss. Now, more recently, we have used the term single-sided deafness to imply that there is no functional hearing in one ear. We have also come out with the term limited usable hearing unilaterally. And that's a mouthful unless you just go straight to LUHU. The reason is that the term single-sided deafness implies that there is no hearing. And that's not necessarily the case. There can still be hearing in that ear, but it's really not usable because perhaps there's a lot of distortion. The speech understanding in that ear is very poor. So we've been using the term LUHU. So let's look at how widespread is this. And I think this is a very interesting slide because we see that when we're identifying infants in the nursery, we're identifying about 1 per 1,000. But as you go through school age and reach adolescence, we're getting up to 14 per 100, which indicates, I think, a number of things. One is that just because a child passes a newborn hearing screening doesn't mean that we don't need to continue to check their hearing and monitor their hearing over time, and that there are a variety of etiologies that might not show up until after the newborn period that we need to be mindful of. Interesting also, Paul and Haffey and colleagues demonstrated and found that unilateral hearing loss progresses to bilateral hearing loss in somewhere around 10% of our patients, which is another reason why we need to pay attention to these children and monitor them closely over time. So why might children with unilateral hearing loss be having difficulty? Well, we know that binaural hearing, or hearing in both ears, is important for a number of reasons. It helps us hear to have two. So it's not just that one is good, two is better. It's more a matter that there's certain things that we can't do with our ears if we don't have two of them in play. And this is just a slide to remind us that in order to localize sound or identify where a sound is coming from, our ears can tell the difference in time that a sound reaches one ear versus the other, and in loudness between one ear and the other. And a way to look at this perhaps more easily is to look at this binaural advantage, where if you have a loudspeaker, as you see on the left, it's going to hit the first microphone number 1. It's going to hit it faster, and it's going to hit it with greater intensity than the second one. And our brains use those cues to identify where a sound is coming from. So localization is a problem for most children with unilateral hearing loss. And another example of how that's used, so we use those skills to cross the street safely because we can hear if something's coming and turn and look quickly. And it creates there's a binaural advantage that we refer to as the head shadow effect. Another binaural advantage we refer to is binaural squelch. And in this case, having two ears allows us to squelch out, if you will, the background noise so we can focus on what we actually want to hear, which is usually someone communicating with us. So when we started our work at Vanderbilt 40 years ago, we started with some very broad questions. Are children with unilateral hearing loss at academic risk? We moved to what types of challenges do they have? What interventions might mitigate those risks, make it easier for children? Are there genetic factors? So now we're getting, farther along the timeline where we're thinking, are there genetic factors that can predict academic risks? Are there other medical factors? And what audiological factors contribute? So I'm going to talk today about kind of what we have found with all of these questions, or most of them, I should say. Okay, so the first question, are children with unilateral hearing loss at academic risk? Well, back in the very early study, this one again, published before some of you were born, I recognize, in 1986. We just obtained case history data on children who had unilateral hearing loss. So we looked at the records of 60 children with unilateral hearing loss in Middle Tennessee. They were school-age children, and we looked at their medical and educational case history data. And this is what we found. As you can see here on the left-hand side, we found that children with unilateral hearing loss were failing a grade in school at a rate of about 37%. That was compared to about 3.5% of children in the general population who did not have hearing loss. So children with unilateral hearing loss had a 10 times greater risk of academic grade failure than their normal hearing counterparts. Well, our colleagues didn't believe us. They thought, oh, that's a fluke. You must have some data that are skewed in one way or the other. And so, although good friends, Euler and Madkin, Bob Euler and Noel Madkin at University of Arizona replicated our study. And as you see here, they found the same thing we did. They found that children with unilateral hearing loss were at a 10 times greater risk for grade failure than their normal hearing counterparts. Now, they had a lower failure rate in general for both populations, but that's just because that varies state by state, which is also a reason why failure rate today isn't considered a great outcome measure to use, but we'll look at other things as we move forward. So after that time that we published the first articles on unilateral hearing loss, there were a number of other papers that came out throughout the United States and also throughout the world, confirming that, in fact, that there is an negative educational impact on children with unilateral hearing loss. So I think that question was fairly well answered. We found that whether it was that children had to repeat a grade in school, or if they just had IEPs, or in other words, needed some special education support, that about 50% of children needed some kind of educational support and were having academic difficulty. And that's still consistent finding today. So are children with unilateral hearing loss at academic risk? Yes, the data are overwhelmingly present for that. So what challenges do they have in school? How about listening and noise? Is that a challenge? Well, again, going back to the old data, and I'll have to walk, some of you probably aren't used to looking at this kind of figure, so let me just explain it for a minute. So if we look at the bottom, on the x-axis, across the bottom, -10 to Q, which stands for quiet, we're looking at difficult listening environments. And -10 means that the voice that we want to hear is 10 decibels below the noise. And so obviously that would be a difficult listening situation. If it's 0, that means that the noise and the voice that we want to hear are at an equal level. And then we take it all the way up to quiet, which would be the easiest listening level. And then on the y-axis, percent correct indicates how many words are correctly identified under those noise situations. So you can see, if you look at the circles up at the top, we're looking at children with normal hearing. And these children, even if they are in a difficult listening situation, a -10, then even if they have normal hearing in both ears, they have trouble. They're understanding less than 60% of what they hear. But as the acoustic conditions get better, then they, in fact, are almost at 100%. Now, when you look at the triangles, what we're looking at there are children who would be like a preferential seating condition. In other words, the speech they want to hear is aimed towards their normal hearing ear, and the noise is going towards their poorer ear. And in that situation, you can see a similar pattern to their hearing. It gets better as the acoustic conditions get better in terms of their understanding, but they're still a little bit below those children with normal hearing in both ears. And then if you look at the squares, we're talking about children who have the desired speech signal or the voice going to their poorer ear with noise to their good ear. So that is not a preferential seating condition. That's the hardest one that they could reach. And of course, you see very poor performance. Now, in fact, it's interesting to note, as you see here, those children, even in quiet, if the desired signal is aimed towards their poorer ear, they still have difficulty. So it wasn't just the noise alone causing the problem. It was just the fact that they don't have that binaural advantage that we have been talking about. And in fact, even though that was a long time ago, and I'm not going to go over this slide in detail, but I just wanted to note that Reader and colleagues found the exact same thing that I just shared with you, that children, even with unilateral hearing loss, even in a quieter situation, have poorer speech perception than those with normal hearing in both ears. And again, there have been many studies that have come out that have also demonstrated that children with unilateral hearing loss have difficulty with speech perception in a variety of different listening conditions. So unilateral listeners are significantly disadvantaged in noise compared to their normal hearing peers. And normal hearing listeners, even if the normal hearing listeners have one ear masked. In other words, maybe they have an earplug in that other ear. The unilateral hearing loss children still are performing more poorly than those children. And it doesn't matter whether the direction of the noise is going towards their normal hearing ear or towards their poor hearing ear, they're going to have more difficulty than their normal hearing peers. So do they have speech perception challenges? Yes, that's indisputable also. Are children with unilateral hearing loss at risk of speech language challenges? How is their speech and language development? Well, there have been a number of studies, excuse me, as well as our study. So our study back here in the day showed that children with unilateral hearing loss varied greatly as to whether or not their speech and language were impacted. And so have other studies. It really depends on what kind of test they're using, what skill they're trying to tap into. As all of you know, there are a lot of skills associated with the development of speech and the development of language. Not all of them are impacted by unilateral hearing loss. This is an especially interesting study to me, and this is one by Liu and colleagues, where they designed a sibling-controlled study of school-age children with unilateral hearing loss, 148 children. And what sibling-controlled means is that children with unilateral hearing loss were enrolled, and their siblings from that same household who had normal hearing were enrolled as the control group. And that's very important, we know, because home and family communication can impact one's development of speech and language. And so that helped to mediate that factor of what's going on in these children's homes. So I love the study design on this. They did find that children with unilateral hearing loss had poor language comprehension, oral expression, and oral composite scores. And then this is a different Cho Lu, in another study, was looking at infants and toddlers, because before these studies started coming out, we were assuming that the difficulties children had academically were because the classroom acoustics were poor. But this was interesting and got us thinking in a different direction, because in the Lu study here, that they found that the average age for first words was right around 12 months, which is normal for the development of first words. But the age for first two-word utterances were significantly delayed, almost 2 years of age. And then Kishan Rabin and colleagues found that 41% of infants showed delays in pre-verbal vocalizations, again, making us start thinking differently about when do these problems and difficulties start with children with unilateral hearing loss. Maybe it's not while they're in school. So on average, children with unilateral hearing loss are at risk for delayed speech-language development. They have poorer verbal cognitive scores than children with normal hearing, and poorer oral language scores than children with normal hearing. So are they at risk for speech and language challenges? Yes, they are at risk. We don't always find it, not every study finds it, but they certainly would be considered at risk. Are children with unilateral hearing loss at risk of behavioral problems? Well, when we conducted our early studies, in fact, we found that they were. We found that if you look at the left-hand side of the chart, you'll see that almost 40% of the children in our study with unilateral hearing loss were rated by their teachers as having poor behavior relative to their normal hearing counterparts. And the behavior problems that they noted, that the teachers noted, included social withdrawal, inattention, distractibility, and in some cases, aggression. Additional studies, so again, they're back in the 80s, we found that. Again, the Liu and Ty Murray study in 2012 also showed that teachers reported high levels of negative behaviors. The assumption has always been that this is because children with unilateral hearing loss may be frustrated in a classroom setting where they're having difficulty being able to tell where a speaker is coming from, where are they, because of poor localization. Maybe too much background noise is causing difficulty in their understanding of speech, which would eventually cause and contribute to some of these behavioral difficulties. So I would say in terms of behavior problems, I still kind of have a question mark on that, because I would like to see what about are there behavior problems in children who are using some hearing technology that would aid them in a classroom setting? And I don't think that question has been answered yet. Another thing to think about is whether, well, if we go back, and as Kathy said at the beginning of the introduction for this conference, she said that we started this work before newborn hearing screening, and that's right. So is the fact that these children used to be identified later than they are now, is that a factor in the reasons for them having difficulty in school? Would earlier identification make a difference? So this is what we found when we conducted this work back in the 80s, that children, as you can see, most of them were identified with unilateral hearing loss at around 5 to 6 years of age. That would be about the time they started to school and received a hearing screening. Interestingly, today, about 43% of children with unilateral hearing loss are identified before 6 months of age. So that's a big change. But are we seeing any differences in their academic settings? So we'll have to see. And it's difficult, another Yogi Bearism, it is difficult to make predictions, especially about the future. So we will move forward and see how we're trying to address some of those questions now. So how do we determine which children are at risk for having difficulty? Are we treating all children the same? So if they have unilateral hearing loss, then we have a set of recommendations that we're making. Is that how we are currently managing these children? How do we make that determination? Well, at Vanderbilt, we have started some current work using what is called the synthetic derivative database. The synthetic derivative database is a mirror image of the electronic medical record at Vanderbilt, but it's been de-identified. So we don't have people's names. It's not exactly a birth. We're close to their birth dates, but the birth dates are off just a little bit so that it's not an exact identifier. And right now, the synthetic derivative contains more than 3 million, and this slide is probably about 6 months old. So we may be up to 4 million by now because we're enrolling, we continue to enroll individuals, and because we continue to receive more patients. So we probably have around 4 million right now. So we conducted a study, and it's called a FEWAS study, where we have over 3 million medical records. We have 300,000 DNA specimens that can be matched. And 90,000 of those DNA specimens have been genotyped. Access to that level of data will help us come up with better answers than we were able to so many years ago when we brought in 25 children with unilateral hearing loss to test. The difference in just the sheer numbers ought to allow us better access to information. So what we did is we started with 3 million records, around 3 million records. Out of that 3 million, we had about 21,000 children with unilateral, or individuals with unilateral hearing loss. When we said we wanted to look at school-age children, then we narrowed our sample to 3,800. And then we wanted to narrow it further to those children who had audiology clinic appointments. And the reason is that we have notes in audiology clinic appointments that can tell us things about about a child's educational progress. Keep in mind that when you're looking at a medical record, it's not likely that you're going to find much education information in that medical record. And therefore, being able to go into the audiology notes where all of our audiologists write things in the case history about how a child is doing in school, we could capture some of that information. So that's why children needed to have had an audiology appointment at Vanderbilt where we had access to those notes. And then we also did a manual chart review on about 500 of these cases. We excluded some and ended up with a cohort of 471 children with unilateral hearing loss for our study. So what we found, yet again, was that about half of these children in this cohort with unilateral hearing loss had educational difficulties of one form or another. They either needed speech therapy, had language difficulties, they needed educational services, they might have repeated grades in school, or there were parent or teacher concerns about the child's academic progress. This was, well, it was confirming for us, and it felt good to us that after looking at this many children, these results essentially are saying the same thing that our early studies in the 1980s said about these children. So that was important to us. So thus far, and we still, because what we did in the first study is created that database of children from the electronic health record, and we can ask all kinds of questions. And so we've started looking at what are the medical factors that might be contributors to the difficulty that they're having in school. And we found that the factors that there were two factors that more than doubled the risk for academic deficits in about half of these children. Prematurity was one, and laryngotomy tubes or having conductive or mixed hearing loss was the other. So these two factors were significant in terms of predicting which children would have the most difficulty. We found that sex, laterality, or whether the loss was in the right ear or the left ear, and the degree of hearing loss were not related to academic progress. So we kind of ruled those out. So assuming that we have a limited capacity for providing care, which we do, if we wanted to prioritize our resources, prioritize those children who need to come in and be seen, this is a start. Doesn't answer all the questions because we're still at a place where we want to continue to monitor, but we can consider that the indicators of prematurity and middle ear disease, conductive hearing loss, ear infections, that kind of thing are strong contributors to the academic difficulty. And what we want to think about when we're doing this work, because we're not the first people to start using the electronic health record to gain additional information for children. And I love this little saying that computers aren't smart, they're just fast, garbage in, garbage out, which basically means that there's some things we can do with the electronic health record and some things that we can't. So I have long been suspicious that congenital cytomegalovirus could be one of the contributors to why some children with unilateral hearing loss have difficulty in school, because we know that congenital CMV can contribute to a more diffuse neurological issues that could contribute to some of the reasons why these children have difficulty. We have not been able to pull those data from the medical records at Vanderbilt. So let me explain why, because I don't want to leave you with the assumption that the electronic medical records are going to assist us and answer all of our questions because of this issue. The cytomegalovirus that results in an impact in hearing is congenital. So it's not and I'm sorry if I'm making this too simplistic, but I know that we have some individuals in the audience today who are not familiar with this term. So I want to be clear about it. It's the congenital cytomegalovirus that impacts an infant's hearing. And if cytomegalovirus is identified after the newborn period, it could have been acquired. They could have caught it after they got home from the hospital. That kind of cytomegalovirus is not the cytomegalovirus that causes hearing loss in children. So what happens in some record keeping in the electronic health record is that somebody just checks the box congenital CMV when they don't know it was congenital. It could have been CMV that was acquired at, well after birth. So because of that, we found that the entry in our medical records was not reliable for CMV, so we have not been able to add that to our study. We are working on it, and I'd love to talk with someone who might have better insight on how we might tackle that problem with the large numbers that we have within a medical record. So I would like to stop here and see if there are questions from the audience.
Thank you. That was a great overview of a huge body of work. And as the questions come in, I'll pose a question. Have you done studies on listening fatigue in these kids?
Yes, and if you stick around after after the break, then in my second presentation, I will be presenting those data.
Perfect. That's great. I'm just going to pose a few questions while Lisa and Janet are screening the questions, or processing, I guess, the questions, because Lisa said we're not screening, we're just processing. But did you know, because the kids with unilateral conductive hearing loss, we see a lot of kids with microtoneural atresia, with congenital maximal conductive hearing loss. Are those kids different than the kids with unilateral sensorineural hearing loss, or the kids we describe as single-sided deafness?
So it's a great question. The data that is out there on those children would indicate that they are not different, that they are also at risk in the same way that children with a sensory or sensorineural hearing loss are at risk. I don't think have been enough studies for me to say, oh, that's definitively they're the same, but there are a couple of studies out there that suggest that they are also at academic risk, even if it's a permanent conductive loss.
Yeah, I think Judith has done a lot of those studies.
Yeah.
But Dr. Horn has a study, or Lisa, are you going to read the questions? Or would you like me to? I'll read them. At Vanderbilt, are you obtaining the blood spot to diagnose congenital CMV post-hoc? And do you know how long the blood spots are kept in your state?
So it's a good question. It's something that's concerned me for some time. So unfortunately, I think the blood spot is only kept for a year in Tennessee. And the last time I checked, I think in Washington State, it was like, you can tell me, but it was like until they were 18 or 21 or
20 years.
Yeah.
So we use them a lot.
Yes. So a pilot study has just started at Vanderbilt to do universal CCMV screening in the NICU, as opposed to a select CMV screening. And they are looking at urinalysis and also saliva. They're not using blood spot.
Okay, the next question. When you said we're not treating the same, how do you know when to aid or not to aid a child?
So that's a great question. I love that. And again, I'll be talking about that. So So the way that, and I probably should have said this at the beginning, what I tried to do with the presentations is to provide what kind of the information we know, the background information, and then talk more about treatment in my second presentation. So it's a wonderful question from Jenny, and I hope I will give you sufficient information that you will feel confident going out and knowing when to aid and not to aid a child.
It's a tricky question, and we'll have a group presenting some data also. Here's another question. Is data showing conductive PE tubes impact outcomes for risk if in the good ear or in ear that already has a loss?
So those data that you're referring to indicated that they had PE tubes or conductive loss in both ears. And so the assumption, at least the way I think about it, and we don't know because we just have the answers to those questions, that they had conductive loss or PE tubes. We don't know a lot of the specifics. We don't know if it was associated with hearing loss. But one can, we do with the conductive loss, but sometimes kids get PE tubes and they don't actually have a loss, but that's in a pretty small percentage of the kids. Most of them are going to have some. My assumption is that sometimes children can do fairly well with normal hearing in one ear. But if you're a child who has recurrent otitis media, where even your better hearing ear is reduced, and perhaps your ear with the unilateral loss is further reduced, and even the fluctuating nature.
Yeah.
I'm very interested in that study, which is
Yes.
a difficult one to do because one would have to test them on a daily basis practically. But I think that uncertainty and that change in the hearing and fluctuation is likely what's causing so much trouble for those kids. Yeah.
All right, here we have another one. My almost 4-year-old son has congenital single-sided deafness. He had an IFSP but did not qualify for an IEP. He's not successful at his mainstream daycare, though. Any suggestions?
So he might, just because he's 4 and will be entering the general school system, I think that there are a couple of things. One is that he might be eligible for a 504, and that's through the Rehabilitation Act. It's another avenue for children who don't qualify in a particular school district for an IEP, and you can still get some services provided. If he's not successful in his mainstream daycare, there are some options, and I think our other speakers today will be talking about this, and I'll be talking a little bit, but probably for older children. But there are sound field remote microphone systems that can be set up in some classrooms where the teacher wears a microphone and a better signal to noise ratio and speech can be heard through an amplified system. That's not perhaps the best option for a 4-year-old because their environment is changing quickly, but there's a plethora of remote microphone systems and designs right now that can be very personal for your child. So I do think that that's still a possibility.
And I don't know if Grace is on as a panelist to talk about, trials of things like bone conduction sound processors, band retained bone conduction sound processors. I'm not an audiologist and I try not to pretend to be one. I would defer to Grace, but I think we'll be covering some of those. I think we'll be covering this question in the afternoon session.
Great.
So hopefully you'll be able to stay around. Let's see, have you had the opportunity to look at hearing assistive device use as a mitigating factor for speech and language, behavior, or academic difficulties? And I think that's what you're going to get to in your next talk, Riley.
I will get to it somewhat. I'll be looking at how the assistive devices aid in understanding of speech, aid in speech perception. I don't want to, kind of give the end of the story up front, but there aren't good data to suggest that hearing assistive devices are mitigating for speech language difficulties and academic difficulties. We just don't have the data. In other words, our academic difficulty rates in these children remain up at around 50%, and it seems to be regardless of whether these children are using remote systems or other assistive technologies. It's not to say they're not working. It's because it is improving their ability to hear and communicate in the classroom. But we have not been able to demonstrate that it has an impact on their academic difficulties at this point. And it could be that we're just haven't been measuring the right things, not looking, we don't necessarily know how long has a child been using the technology, how consistent are they using it, how consistent are the teachers ensuring that the technology is working on, there are a whole lot of questions that have to be answered before we could have a conclusion on that question. It's a great question.
All right, thank you. We have some more. In 2000, we did a hearing screening of special education students, juniors, and found 17% of the special education students were at risk for unilateral hearing loss. And that was at Sweetwater Union High School.
Yeah.
Once the older students were told about behavior issues attributed to their unilateral hearing loss, they were more able to advocate for themselves in a meaningful way. That's interesting.
It's very interesting, and I appreciate that comment. I think that some of what happens with unilateral loss, as well as minimal hearing losses, and when I say minimal, I mean bilateral, so in both ears, there's a slight degree of loss. I think what happens is it's hard for teachers and other students and others around these individuals to recognize that they really do have a listening difficulty. And when people forget, because it's not as obvious perhaps as a more severe hearing loss, then they don't try to accommodate it in the same way. They're not tuned into ensuring that the environment is quieter for these children, or that they are directing the speech signal to the normal hearing ear, those kinds of things. And I think there's a sense that maybe they don't feel believed that they're having these difficulties. So I think part of what we want to do as professionals and other individuals who care about these children is to make sure that school systems and others are aware that these are real problems for many of these children. And again, I don't want to overemphasize. I want to point out that we're still looking at 50% of these children are going to have these difficulties. That means about half of them aren't. About half of them are going to be able to modify their surroundings on their own, advocate for themselves. They don't have these difficulties, but half of them do. So I think it's up to us to continue to educate the teachers and other professionals and parents who are with these children, we need to let them know what kinds of difficulties and what they can do to help. So thank you for that statement, Janet.
Yes, I think that's really powerful. The second part of that comment is really powerful, and perhaps something that we as professionals don't do enough of, really encouraging the kids, the patients, to advocate and teaching them those skills, because they're not skills necessarily that people come to naturally,
Right.
children or adults. And so I think that's really powerful. Thank you for that. Are there any slides, are there any studies regarding the social emotional skill developments of the children with unilateral hearing loss?
I don't know. We did not, in our sets of studies, and I don't know, maybe Dr. C knows if Dr. Lou has done these. I mean, she's someone else who has done a lot of this kind of work, but I am not aware of that.
Yeah.
Now I say no. Back many years ago, we looked at a series of questions about questionnaires that were posed to these children with unilateral hearing loss about how they felt about themselves, how they felt about how they were treated. So there's some studies around that.
Yes,
but they're old that I know of. Yeah.
there are some studies in the kids with unilateral oral atresia that Judy Liu has done. And then Grace is going to talk, Dr. Chang is going to talk later about a self-reported instrument for kids with unilateral hearing loss. And that was developed in Seattle with focus groups. And so that's turned out to be an interesting tool. So we'll answer one more question before closing this Q&A. For those kids with unilateral hearing loss, are you sending them to ENT more quickly to consider ear tubes compared to kids with normal hearing?
I certainly hope so. I think that I'm not in the clinic any longer, so I'm not part of that care pathway. But I know that our audiologists work very closely. We're in the same building with our otology colleagues. I would certainly, given the data we have about the impact of conductive hearing loss on these children, I would think we would be a little more assertive about making sure that they get an evaluation by their otologist to consider tubes if they are experiencing recurrent otitis.
Dr. Chang, do you want to chime in?
Could you repeat that question?
Oh, for those kids with unilateral hearing loss, are you sending them to otolaryngology more quickly to consider ear tubes compared to kids with normal hearing?
Generally, at our practice in Seattle Children's, if we are dealing with a kiddo who has hearing devices, any level of hearing loss and chronic otitis, I do believe that our audiologists are sending them to ENT more frequently, just because it is going to impact, I call it chasing a moving target when we're programming hearing devices. If we have that conductive component on top, kind of making the thresholds fluctuate somewhat, it makes it more difficult to program a hearing device. So I would say that regardless of unilateral or bilateral hearing loss, we tend to refer to ENT more quickly when they're dealing with any sort of conductive middle ear dysfunction.
And I would say from the otolaryngology or ENT perspective, we probably have a lower threshold for putting tubes in the kids with any degree of underlying hearing loss. So thank you everyone for that robust discussion. And I love the idea of teaching coaching our patients on how to advocate for themselves. But with that, we'll take a break and reconvene and plan on starting promptly at 9:45.